thrombocytopenia is not so frequent in lower risk MDS, but we want to discuss it. These are my disclosure. The incidence of cytopenias in low risk MDS, it's quite different, anemia being the most frequent, and cytopenias like thrombocytopenia accounting for around 30% of cases. Nevertheless, thrombocytopenia can induce fatal bleeding, although in a small proportion of patients. As a matter of fact, only a very small minority of MDS lower risk patients do have platelets below 20,000 microliter. Thrombocytopenia can induce fatal events, but bleeding from thrombocytopenia in low risk MDS is quite rare. Progression to AML and infection being anyway most frequently causing death in these patients. Now, the importance, as a matter of fact, as prognostic factor has been recognized long time ago. Thrombocytopenia is in fact impacting on prognosis in a significant way. Even the level of thrombocytopenia is critical. And this is the pivotal work of the MD Anderson. And you see that thrombocytopenia below 50,000 can impact on survival with only 15 months survival and 19% of patients still alive at 4 years despite lower risk MDS. And the importance of the depth of thrombocytopenia and other cytopenia has been recognized lately in the IPSSR system that we now use for stratifying prognostically MDS. I want to discuss some cases to let you understand the importance and the difference in the causes of thrombocytopenia in lower risk MDS. This is a female patient, age 59. She comes with a good general condition, and she has been followed for several years for MDS with multilineage dysplasia, but IPSS low risk and stable values without profound cytopenias. Then suddenly she presents with rapidly worsening cytopenia. As you may see, especially the number of platelets has decreased from the last control. She has also worsening anemia and neutropenia. Therefore, suspecting progression, we perform a complete reevaluation of the disease with bone marrow aspiration, biopsy, cytogenetics, and an NGS panel to look for new mutations. But because of the low level of platelets and because we wanted to perform a biopsy, we perform also a platelet transfusion immediately before the procedure. And when we control the blood counts, we see the platelets are much lower than before. And there is also a direct Coombs positive test. Bone marrow aspirate is superimposable to previous one, but there is a megakaryocyte stimulation. There are no blasts, no megakaryotype. The biopsy confirms the strong stimulation of megakaryocytes. NGS indicates the presence of two mutations, TAT2 and SRS2, with 37 and 45 variant allele frequency respectively, and very slightly increased, only very slightly increased from the previous determination. Therefore, this patient has now an IPSSR score of 3.5, intermediate risk. For this reason, we accelerate the transplant program for the patient, but we have the idea that this patient may have ITP given the response, the worsening of platelets after transfusion. Therefore, we treat her with corticosteroids, prednisone 1 milligram per kilogram per day for 3 weeks, like normal ITP, and we check counts after treatment with noting an increase, a significant increase in platelets and also in hemoglobin. Now, if you reevaluate the patient, the IPSSR score is now very low risk. So the patient has been put in close follow-up, but transplant has been postponed. Now, 17% of patients with lower-risk MDS may present immune cytopenias, anemia, and frequently thrombocytopenia, to be suspected, especially if the level of platelets is very low. What is the impact on prognosis of this ITP accompanying MDS? Now, as you may see here on the left, you see that the overall survival of patients with ITP and MDS is slightly better, not significantly, but slightly better than the other MDS. So there is no worsening of the prognosis of this patient, whereas, of course, ITP patients have a much better prognosis. But regarding progression to leukemia, the presence of autoimmune thrombocytopenia seems to favor the patient, and there is less progression to AML. Now, about the treatment, ITP in MDS, in low-risk MDS, do respond very well to corticosteroids, exactly like isolated ITP, and the same is true for intravenous immunoglobulin. Therefore, the first course, the first line treatment should be exactly the same as the one we apply for ITPs. This is an algorithm. We have to think about immune thrombocytopenia in lower risk MDS, especially if we see a bone marrow, like in our case, in which megakaryocytes were stimulated. If the platelet transfusion is completely inefficacious, or even in our case, even worsening thrombocytopenia. And the first thing to do is to treat with glucocorticoids. And if there is a good response, just keep the patient under control. And in case of relapse or in case of no response, think about applying TPO agonist. The second case is different. This is a male patient, age 60 years, Asian descent. It comes to us as a second opinion in very poor general condition, referred with a diagnosis of lower risk MDS with multilineage dysplasia, with severe progressive thrombocytopenia. He receives transfusions, and when he comes, he is transfusion dependent, receiving danazol, but he has diffuse purpura and epistaxis, and these are his counts. Now, we reevaluate the case completely, and the counts we have indicate even a lower level of platelets, 7,000 microliter. The bone marrow aspirates confirm that is a lower risk MDS because there is a multilineage dysplasia, but especially megakaryocytes are severely dysplastic and have reduced dimension. No stimulation, normal karyotype, no fibrosis at biopsy, but presence of several micromegakaryocytes. The patient shows a mutation of U2AF1 gene with a variant allele frequency of 40%. His IPSS score is 2, low risk MDS. After 1 year of treatment, despite the fact that the platelet values were very stable, above 50,000 microliter, the patient suddenly decided to interrupt treatment with actually no reason, apart from the fact that he didn't want to come to the hospital any longer. He has progressively lost response, and when we check again the values, platelets are extremely low. There is fibrosis at bone marrow biopsy and hypocellular marrow, but no sign of progression. The patient refused any treatment, even erythropoietin. And of course, we refer the patient for haploidentical stem cell transplant because he has severe bleeding episodes. So this is the design of the study in which the patient was enrolled. A thrombopag was compared to placebo, is single blind, so we knew that the patient was taking the drug. And we had at week 24 to check for CR and partial response. In fact, at 8 weeks, like in our case, the median platelet count was increasing significantly, and in some cases, even the hemoglobin erythroid improvement was noticed. Now, the cumulative effect of Thrombopac was quite clear in this study. But we have two drugs that are possibly useful for thrombocytopenia in MDS. One we already saw, Thrombopac is an oral drug, TPO receptor agonist, and then romiplosting. Romiplosting has a different molecule, is administered subcutaneously, and is approved as a Thrombopac for ITP and a Thrombopac also for aplastic anemia. Both drugs are effective. These are the two studies. So the study I just mentioned led to a 47% hematological improvement in platelets, and the romiplosting study with the 700 micrograms per week led to 36% response. The latter drug was evaluated in this study in 2014, but it was published in 2014, but stopped in 2011 because some progression to AML were observed, and then the study was put on a halt. But if you then see the efficacy of the drug is present, and the 5-year long-term follow-up, in fact, indicated that the increase in blasts were only transient, and there was not a significant progression to AML in treated patients. And in fact, the efficacy was clear, and in some cases, I've previously mentioned, you see that there is an increase also in erythroid and neutrophil lineage. There is also the attempt to find a model of response. Factors predicting response to romiplosting are the baseline TPO, endogenous TPO level, the number of platelet transfusion units needed, and you see that you may create a score similar to what we are used to have for ESAs. So we know a lot about these two drugs, but none is approved for MDS. They are both active. They may indeed stimulate early progenitors because they can induce increase in neutrophils and in red blood cells. They have, romiplosting has shown a transient increase in blast in the bone marrow, and both drugs may have a role also in association with HMAs, but there are some studies only in higher risk MDS. The third case is different. This is a patient, age 71, acceptable general condition, dysplastic CMML, lower risk, treated with ESAs for many years. And he comes with a partial loss of response, anemia, but the most important feature was a severe progressive thrombocytopenia that made him platelet transfusion dependent. The bone marrow biopsy didn't show any progression, depressed megakaryocytes, and a good cellularity, and moderate anemia. The patient has a normal karyotype that has 3 mutations, TAP2, EZH2, and ETNK1, all with a very high variant allele frequency above 40%. Having reevaluated the patient in this way, and having seen that his absolute neutrophil count is normal, we consider that this patient is still a low-risk patient. And HMAs are off-label in Europe, but in this case, we consider that this could be really the solution and a good treatment for the patient who is losing response to ESAs, has severe thrombocytopenia. And in specific, we enrolled the patient in the investigational randomized protocol CC486, oral azacitidine versus placebo. And he started receiving the drug with a progressive improvement in platelet, and he has stopped to receive transfusion and also shown an increase in hemoglobin. During treatment, nevertheless, he showed a neutropenia grade 2. Now, we know that oral ASA may be very active in lower risk MDS, both with low platelets or high platelets. In terms of overall response rate, you see we can reach even a level of 46%. On the other hand, we have data indicating a very good overall response rate of 62% in patients receiving low-dose decitabine and azacitidine 3 days, with quite a good response and a long-term response. So HMAs can be used in a lower risk MDS with some success. The patient I presented was enrolled in this phase 3 randomized study compare CC486 to placebo. The patient was receiving 300 milligrams a day per 21 days, plus, of course, best supportive care. And after cycle 6, the response was assessed, especially in terms of transfusion independence, both for red blood cells and for platelets. The patient, if responding, could continue treatment, and then survival, progression to ML, and needs for other treatment were evaluated. The patients could be included if they had thrombocytopenia with platelet counts below 70,000 per microliter, confirmed in 2 separate days, and transfusion dependence that our patient had just started to have. As you see, the study indicated that CC486 can induce significant platelet increase together with transfusion independence for red blood cells in low risk MDS patients with this, let's say, severe thrombocytopenia. The response in terms of platelet hematological improvement was near to 25% for patients receiving CC486. So indeed, a successful treatment that can be considered for patients with lower risk and MDS and thrombocytopenia. Now, the role of CC486 has still to be established now that ASEX 727 has been approved for treatment, or decitabine has been approved for treatment of all types of MDS. I think that oral treatment is going to be the future for these lower risk chronic transfusion dependent patients. I finish here. I wish to thank you, and I'm ready to take any question. Thank you.